Next up, it is my pleasure to introduce Dr. Swasticharan, sir. Sir is the Additional DDG and Director EMR at the Directorate General of Health Services, Ministry of Health and Family Welfare, Government of India. Sir is an MD in Community Health Administration from Delhi University and an MPH from Massey University, Palmerston North, New Zealand. Sir is a WHO Fellow in Health Impact Assessment at Liverpool University, United Kingdom, and was also trained in the Leadership Program in Global Tobacco Control at Johns Hopkins School of Public Health, Baltimore, US, and in the Public Health Leaders Program at Emory University, USA. His areas of work inter alia many public health issues are integration of health programs for synergistic, better implementation of programs and scientific evidence to policy to implementation, systems thinking, and innovations in healthcare delivery. We are grateful for the leadership and the guidance that he has given us in the drafting of the operational guidelines and for the steps in implementation that are envisaged under those operational guidelines. And I welcome you, sir, today. Thank you for spending your time to share your expertise. I know that you are known for your acumen with regard to implementation of health programs. And I welcome you for the plenary session on integration of NAFLD into NPCDCS, key strategies and operational aspects. Over to you, sir.
Thank you. In the next 15-20 minutes, I would like to spend some time with you trying to explain whatever has been explained for non-alcoholic fatty liver disease. How do we integrate into a program called NPCDCS, the flagship program, which I have been looking after in the past few years as a part of the NCD team. I have moved out of the NCD team to look after entirely on the emergency medical relief because of various requirements of the emergency medical relief in nature, which is happening here. Nevertheless, I am a fan of NCD and the risk factors which is happening in the country. So I have decided to spend some time with you trying to explain NAFLD into NPCDCS. It started around 1975 when India started addressing the NCD challenges with the vertical programs. And we had started some activities around that time, but it was only in 2008 when there was a pilot in 10 districts, which increased to about 100 districts in 2010. And the arrival of NHM happened in 2013-14, where it was rolled out to about 36 states and UTs, increasing to 468 by 2015-16. And the paradigm shift happening around 2018, where we have the development of health and wellness centers and the introduction of population-based screening for the common NCDs. And in 2020-21, we had a new edition of what is known as NAFLD into NPCDCS. This is in brief from 1975 to 2021. The objectives of the NPCDCS program obviously would be health promotion and population-based and the opportunity screening, meaning that you still have the population-based with the ASHA coming to your doorstep, but we still also look after those patients who drop in at the healthcare facilities in the PAC or the NCD clinics at the CAC and the district hospital. And also we try to do a lot of activities for prevention and control of the chronic NCDs. And we try to build capacity like what we are trying to do this, spread awareness about the risk factors and the NCD services. And we also support a lot of diagnostic and cost-effective treatment at all levels. The structure, infrastructure consisting about the actual clinics where the NCD patients can drop in at the CAC level runs to about 4,800. And we also have the daycare centers for chemotherapy in 239, 190 cardiac care units as well. And at the district hospital level, we have about 643, and the number is still counting. And to run this program at the district NCD cell, the administrative cell at the district level is in about 678 districts, and all the states, as I said, and the UTs have the NCD cell. Now, speaking to a little bit in detail about the population-based screening, This was a package launched under the comprehensive healthcare in 2018, and the ASHA comes to your doorstep and enumerates all the members of the house, and those people above 30 years of age, they are again targeted for screening for the common NCDs. And they also ask a lot of questions as per the community-based assessment checklist or the CBAC form, and by virtue of asking these questions, it also generates lots of awareness. If somebody asks you, do you smoke? Then if you're a smoker, then you start thinking why this person is asking. Then the next question is, do you take alcohol? And how much is your physical activity? Then all this, and then the parameters about the height, weight, and the abdominal circumference, and so on. So all this generates a lot of awareness on the risk factors for the NCD. So these were also a screening for the early detection of the disease, as well as a very effective way of IEC, which we have been doing during this population-based screening. And non-alcoholic fatty liver disease, when we try to introduce this, we would like to know that is this something different from the core NCD program that we have been doing. It is, if you have listened, you have already listened to all the speakers before me. Now you know very well that NAFLD, it has got a component which is very, very core to NCDs. And we are not trying to do something new, but we are trying to introduce a concept, a disease, a condition which might help in the actual NCDs and the control activities of the NPCDCS if you take care of the liver. So this is what we are trying to do. And these two go together because of the huge burden both in NCD as well as NAFLD. If you take care of NAFLD, many of the NCDs would automatically be taken care of. And if you see the operational aspect, there are a lot of risk factors which are common between NCDs and NAFLD, and the corrective measures, say increasing physical activity, eating a healthy diet, and so on. These are all common for both NCDs and NAFLD. Why do we emphasize on NAFLD? So it's like, when you have a big target, you focus on many areas of the NCD, which of course is important. And then if you want to really focus on some areas which are the best buys, the best areas where if you take care of them would certainly have a dent on the NCDs of this country, that happens to be NAFLD. So therefore, the emphasis on NAFLD is being considered by the ministry. So we have had the integration by publishing an operational guidelines, which were finalized by contribution with all the important stakeholders. And we have been having a lot of sensitization workshops like the one we are having today to increase the awareness about NAFLD and why we need to do NAFLD into NPCDCS. This is a picture where the minister himself had released the guideline, and we are proud to announce that India is one of the first country in the world to identify the need for action for NAFLD in the component of a national program or for NCD. But how do we implement this? If you have noticed what I had explained earlier, the NAFLD components are nothing new. We are trying to tweak a little bit of what's happening for the NCD, ongoing NCD, to fit the requirements of NAFLD, like health promotion, awareness generation, promotion of healthy lifestyle. This is common for both. The screening and early detection, we already do it for the common NCDs, which we may tweak a little bit of what is already being there, a little bit of a skill on the health worker, or add something in the mobile app that's already there for calculation of, say, for example, BMI, etc. Those are the minor changes which we might bring in NPCDCS to fit the requirements of NAFLD. And we have to pitch in with timely, affordable, accurate diagnosis at the appropriate level, and improve the access for affordable treatment, and also provide rehabilitation wherever required. So the proposed promotion for NAFLD would be planning strategies, and then the mass media, social media, using to promote the key messages. And whenever we are having international or national health days, we can pitch in the liver angle, and then liver for the mere nature of what it functions inside the body, and for the various reasons which has been explained by Dr. Ajay and so on. So we can always bring the liver focus in any of these meetings, in any of the observations of the health days. So the ANMs and the medical officers would then be, easy once they know that once the capacity is built in these people, they can easily further promote the key messages at the health facilities like a sub-center or the primary health center, etc. The community level activities, I had already explained about the CVAC form. Now, when the CVAC form is being filled, the family history is being taken, and then we also measure the weight circumference, and we also waist circumference. We also ask for the physical activity, and then we also ask for consumption of risk factors like alcohol and tobacco products. Now, with the proposed NAFLD, we are already doing abdominal obesity. Now we can interpret, we can teach the ASHA to interpret a little bit of what's already, the activity of what she has already been doing. Then we may increase the family history from the usual diabetes, hypertension to include liver disease, gallstones and cancers, etc. And then we also have the proposed activities at the sub-center level when the ANM, tries to validate the findings, those cases which are referred by the ASHA by measuring the abdominal obesity, then the BMI calculations, etc., and then screen for the common NCDs, and then refer to the PAC. So these are some of the activities which we are already doing in NPCDCS. Now we may add a little bit about increasing the examination for pedal edema. This won't be something new because they have been already doing it for pregnant ladies. So, in addition to the women, they might have to start looking for pedal edema in those patients above 30 years who have been referred by the ASHA. So this is something, it is not a new skill, but it is, reappropriation of a skill which the health workers were already having it, and then we record accordingly in the available form of the NPCDCS, which will be modified. And then the medical officers at the PhD level, the diagnosis, the capacity would be built a little bit, and then they will examine the patient and refer who are those having NAFLD suspects, and then referral to the CAC and data recording, etc. These are already available in NPCDCS. With little tweaking, this can also be recorded. So if you understand now the skill gap is very less. We are trying to build this in all the health workers, and then the data management for capturing the activities at this level till the PAC is also already there in NPCDCS. We may have to tweak a little bit to include NAFLD for our records purpose, for our analysis purpose. Now come up to the CAC level, then the activities which we're already doing there, catering to the referred patients, and then the capacity building being happened there. Now you can tweak them as per the need of the NAFLD by providing the diagnosis, by providing the capacity building, etc., and also referring them to higher facilities like district hospital. Let's go up to the district hospital. Again, this is the upper portion shows the activities that's already happening, the data capturing method which is already happening, the capacity building, etc. But now with NAFLD, we may have to have a little bit of tweaking on how the NAFLD referral system is there. Then the doctors will have to build their skill and will have to build their capacity for the risk specification of the advanced liver fibrosis with facility for diagnosis like an enhanced liver fibrosis test or a fibroscan. And we may have the capacity building which will happen in a cascade manner from the center till the sub-center happening, most of the capacity building happening at the district level. And then if the facility is not adequate to treat that stage of disease in NAFLD, then we can still refer them to higher centers, which are the medical colleges or the central government institutes where the risk stratification would be easily done. Then intermediate risk factor, risk for advanced liver fibrosis in terms of fibroscan and other diagnostic facilities would also be available in collaboration with the medicine department or the department of gastroenterology, wherever is available. So this is the referral system that we have, and in order to run this successfully, we might also consider having a national center of excellence, and also when it becomes a very big program component, we may have the regional or the state cancer, regional or state center of excellence, etc. So by now, when we have to do many activities for the NMAP, for the NCDs, we know that health in this area, at least in NCD, is well beyond the health sector. So we may have to involve many line ministries which has got a bearing on the health. Say, for example, the sports ministry for increasing physical activity, then eating right campaign from another branch of the ministry like the FSI, and then all the line ministries which have a bearing on the health, especially on the NCDs. We try to bring them together in what is known as National Multi-Sectoral Action Plan, which India is one of the early countries to have developed. The NMAP prevention and control of NCDs works on various areas with strategic areas and key outcomes already identified. And so taking one of them, for example, say Fit India campaign is targeted against physical activity, increasing physical activity. Then the Ministry of Youth Affairs and Sports has already launched the Fit India as appropriate fitness protocols for 3 categories of age group, like 5 to 18, 18 to 65, and 65 plus age. So here the NCD team in the ministry has also contributed in developing these protocols. And as I said, the Eat Right campaign from FSI is also one component targeted towards healthy living. And in brief, to move forward, we need to prioritize why we are doing NAFLD. Then we also need to include, the OZ, the operational guidelines of NPCDCS, the portions of NAFLD, and also in the PIP guidelines through which the state are going to ask for money and which we are going to provide for NAFLD component. Then we need to monitor them. We need to ensure that whatever is required, as I had already briefly mentioned, like the investigation and the diagnostics and the therapeutics required for treating NAFLD are available at the various levels. Build the capacity, then development of various modules for capacity building, and also monitor what we are doing through the actual PBS, as well as the various formats which may be done in hard copies or electronically. This is how we need to go ahead. At least by doing all this, we know that we are going in the right direction, and we can monitor ourselves whether we are still working at the pace at which we want to work, and also towards the right direction when we want to see NAFLD, free India, as well as greatly reduce burden of NCD. So this is all I have to share with you in these few minutes. Thank you very much.